Dear friends, this is Dr. Keyur Parikh. I am cardiologist at SIMS Hospital, Care Institute Medical Science, Ahmedabad. This is a part of our e-learning series which we have continued for last few years. Today we will be talking on a case of TAVI or TAVR, which is transcatheter aortic valve replacement or transcatheter aortic valve implantation, where we did this procedure in a patient with renal insufficiency, with type 3 chronic kidney disease, CKD, with the use of less than 20 ml, 20 cc of contrast. Transcatheter aortic valve replacement is a relatively new procedure being practiced for last 10 years to implant using a catheter from either femoral artery or other percutaneous approach and implant the aortic valve in place of diseased aortic stenosis or in case of a previously diseased bioprosthetic valve where we implant a valve in valve. This procedure obviously avoids sternotomy, cutting open the chest. So let's go step by step as to how we did a transcatheter aortic valve replacement using extremely very low quantity of contrast in a patient with renal insufficiency. This is a patient where we did a TAVI case with use of very minimal dye. The heart team in this case included myself as primary operator, Dr. Milan Chugh and Tejas V. Patel, who works at SIMS, was with me, and the heart team at SIMS Hospital, inclusive of surgeons Dr. Dhiren Shah and Dhaval Nayak, and anesthetic team of Chintan Sheth, Niren Bhausar and Hiren Dorakia. I have nothing to disclose of or no potential conflict of interest in this program. This is SIMS Hospital with a tall 10-storied building on the left and two-storied building on the right. The right building is where the cardiovascular center is set up. The objective is how to perform a low or no contrast TAVI in a patient with renal impairment. So let's discuss the role of contrast in TAVI. Acute kidney injury is a major concern in TAVI with increasing mortality by 2 to 8 times, more so in patients with CKD. During TAVI, contrast is used for pre-procedural CTA, procedural peripheral aortoiliac angiography, aortic root angiography, positioning of valve with check chutes, post-placement aortic root angiography, and finally post-procedure peripheral aortoiliac angiography. So here we present a case of TAVI for severe aortic stenosis in a 78-year-old diabetic nephropathic patient where we used less than 20 cc of contrast. Patient had stage 3B moderate CKD with a GFR of 38 milliliters per minute. And this patient was diabetic, stage 3B CKD and elderly. The risk of further acute injury is always very high. His other risk factors included G6PD deficiency, diabetes as I mentioned, chronic kidney disease with stage 3B moderate CKD with a GFR of 38 ml per minute, creatinine of 1.7, ischemic heart disease and PVD, history of gastritis and recent GI bleed requiring blood transfusion, but the endoscopy did not show any active bleed. Very active lifestyle. He is a practicing physician and no other psychological abnormalities. Prior clinical history of the patient includes coronary artery disease with PCI in left circumflex and right coronary PD a few years ago using drug-eluting first generation sirolimus cipher stent, both of which are patent. He had left femoral peripheral transluminal angioplasty with the placement of stents 1 month ago. when we used very minimal dye and stable creatinine post-procedure. The presentation this time was severe aortic valve stenosis with severe angina despite patent coronary arteries, class 3 to 4 angina. His is an interesting case because he also had moderate mitral valve stenosis with moderate mitral regurgitation. Laboratory investigation showed hemoglobin which was low, 10.7. Creatinine was 1.70 with the eGFR of 38 ml per minute per body surface area of 1.73 meters square, which is significantly low, defining him as stage 3B chronic kidney disease. His STS score was measured based on the hypothesis that if he undergoes surgery, he would require aortic valve replacement and mitral valve replacement. STS score was for independent aortic valve replacement showed a risk of mortality of 3.10 and mitral valve replacement independently 5.10. There is no cumulative two valve replacement STS score, but overall the risk of mortality, morbidity was high with a long length of stay being 6 to 10% or more and possibility of stroke around 3% and chances of prolonged ventilation anywhere from 10 to 25% and the chance of reoperation approximately 10% and chance of a significant renal failure 5 to 8%. The heart team had a long discussion. This is a 78-year-old man with chronic kidney disease, symptomatic severe aortic stenosis with class 3 to 4 angina. Mitral valve area was 2.10 centimeters squared with grade 2 MR, possibly aggravated by severe aortic stenosis. 4 cardiologists, 2 cardiac surgeons, 2 cardiac anesthetists, and 1 imaging radiologist was involved in 2 separate heart team discussion, where we debated to do surgery with double valve replacement, being old patient, that he would not tolerate another redo at a later date, or a TAVI with low to no contrast. Finally, we decided with the high STS score, whereas the TAVI risk score was 3.8% mortality, and mitral valve stenosis being not significant enough, it was decided to have him undergo TAVI with low contrast. Pre-procedural strategy was defined that we should do a MR angiography and avoid CT angiography, but we were recommended by the valve company that CTA was recommended due to unavailability of MR-based planning and analytics software. Both CTA and MRA subsequently were done. We pre-admitted the patient. Intravenous hydration for 12 or more hours was done using minimal contrast and using a 1.5 Tesla MRI and MR angiography was done of aorta and aortic valve. Detailed transthoracic echocardiography was done. People elsewhere do DSA carbon dioxide angiography for infradiaphragmatic aortic iliac arteries and nephropathy, but we do not do it here. MRI aortic root short was done. You can see in the images a very clear MRI angiography, and the aortic valve can be seen with excellent borders which can be appropriately be measured. The far right shows dynamic MR LV and aortic root angiography. The next slide also shows MRI aortic root as well as very classic aortic valve, tricuspid with mild to medium calcification and fairly stenosed valve. Non-invasive imaging measurement showed normal LV size and contractility with the ejection fraction of 60%, thick calcific severe aortic stenosis with a peak pressure gradient of 88 mm of mercury and a mean gradient of 57 mm mercury, aortic annulus of 21 mm, Aortic valve area was found to be 0.54 centimeter square. Sinus of Valsalva was 36 millimeter by echocardiography, mild aortic regurgitation. Mitral valve was measured, which was mildly thickened, mitral annular calcification 1 plus, adequate opening with mitral valve area of 2.10 centimeter square, grade 2 MR with a peak gradient of 16, mean gradient of 4 millimeter mercury, with a mild pH, RVSP 44 millimeter of mercury. Preoperative echocardiography was done and it shows critical aortic stenosis, as you can see. The Doppler also confirmed the same. Multi-slice CT angiography using low volume contrast, 30 cc and high resolution imaging was done, and a comparative non-contrast CT angiography also was done for peripheral and aorta. The non-contrast angiography can be seen on the right side with heavily calcific system. Femoral access sites right and left were measured, both with contrast, minimum dye, as well as without contrast. And as you can see that the right iliac artery, the external iliac artery and right femoral artery, the measurements have 10% variation. Where if you presume the one with contrast being the accurate one, the without contrast shows some degree of difference, but not more than 10%. Same applies on the left femoral axis. As you see, the difference between the CT with contrast and without contrast, though similar, there was slight error towards the one without contrast, showing slightly larger diameters. CT analysis, which was done with low volume contrast, high resolution, showed the perimeter at 80.3 of the annulus with annulus diameter 19.8 by 29 and the derived diameter 25.6, and sinus of Valsalva diameter 34.9 at the left coronary cusp, 32.4 at the right coronary cusp, and 34.6 in the non-coronary cusp. STJ diameter in the next slide shows 25.9 by 27.0 minimum and maximum, and CT analysis showed sinotubular junction diameter 25.9 and 27.0 as mentioned earlier, and moderate aortic valve calcification. LVOT diameter was 21.7 by 28.7 and maximum ascending aorta diameter 29.6. CT analysis of the coronary ostia showed the left coronary ostial height 15.5 above the annulus and the right coronary ostium height 15.1 above the annulus, and the sinus of Valsalva height above the annulus is 18.8 in the left coronary cusp and 21.3 in the right coronary cusp. CT analysis of the aortic root angle showed an adequate aortic root angle of 50 degrees and a very smooth aortic root angulation. We also decided to compare the CT angiography information and the MR angiography information, and both of them showed similarity, but there was 10 to 15% variability between the two, which otherwise is acceptable, but the MR without a defined software, we were unable to finalize the diameter based on software and we had to use manual measurement. We decided to go with Evolute R 29 mm and we preferred that for its recapturability. The procedure strategy was then defined as follows. Patient was admitted a day earlier with 1 day of hydration with normal saline and bicarb. Since left ventricle was normal, if the left ventricle was poor, the amount of hydration would be less. We decided to go with general anesthesia and TEE, transesophageal echocardiography, and a transfemoral approach. All TAVI supplies, hardware, view box was kept in the cath lab. Double femoral access was done with ultrasounded guided or crossover wire technique puncture. We used the crossover wire tracking puncture. We used the CT scan done earlier to guide for the anatomical landmarks, location of the artery in relation to femoral head, and location of superficial femoral and deep femoral artery bifurcation, and calcium in the arterial wall. Left femoral artery access with the manual palpation and fluoroscopy was done using the landmark on fluoroscopy as well as the CT angiography, which was done earlier, kept in the view box in the cath lab. 5 French sheath was placed. Using a SIM1 catheter, or you can use SIM2 or J.R. Judkins Wright catheter, a crossover was done using a contralateral iliac artery access, and a Terumo glide wire, also known as a radio focus guide wire, was passed from left to right iliac artery as a marker. Using that marker, right iliac artery was right common femoral artery was punctured. We may also leave a coronary 0.018 wire across for potential access from contralateral side in case of post-procedure complication on the right side. We did the puncture using micro 21 gauge needle, and we used 18 French sheath. Again, use of large view box inside the cath lab with the CT angiography images are very useful. And here I am showing various catheters from pigtail to various Cobra catheter, Siemens 1, 2, SIM 1, 2, Bernstein catheter, all of which could be used. Again, I emphasize the use of double view box in the cath lab so that you have the anatomical landmarks available there. Procedural strategy was as follows. We decided to pre-dilate the aortic valve to make the valve crossing easier. However, we have to be careful not to use contrast. Many doctors, many cardiologists do not prefer pre-dilatation, which is also acceptable. If we pre-dilate, the rapid pacing time should be as less as possible to avoid the hypotension. We preferred evolute valve, evolute R due to recapture capabilities, but if you are expert with the sapien valve, that is also acceptable. In CKD patient, there is calcification in the cusp and annulus to guide your deployment, so you do not actually need contrast. When delivering the valve, do it faster to avoid prolonged hypotension. Use TE as required. Very minimum dye can be used in the pigtail, which is placed in the non-coronary cusp for check shoots, or you can use transesophageal echocardiography to see the positioning. Post-dilatation to be done only if needed. Let us now review the film, the recorded case. We are putting, using a fine needle and using the contralateral tracking wire, we access the right femoral artery and used the 2 ProGlide sutures to begin with. Sheath was inserted, 18 French. Once we did that, using AL1 catheter and a Terumo wire, radio focus wire, we crossed the valve. On the AL1 which was introduced, a standard J wire was placed, a pigtail, and finally Confida wire was placed. Balloon dilatation was done and the aortic valve was opened. Subsequently, a 29 mm evolute R valve is being inserted over a Confida wire. Confida is a Medtronic wire. Boston makes a Safari wire which is similar. So far we have not used any contrast in the procedure, as you can see. We used the proper positioning of the pigtail in the non-coronary cusp and TE guidance to properly place the valve 3 to 4 millimeter below the annulus, and slowly started deploying the valve. So far we have still not used the contrast. Now we use 5 cc of contrast. We did intermediate pacing. Another 5 cc of contrast was used, and finally the valve was deployed. TE reconfirmed the position and the widely patterned valve. Lack of gradient was established. Finally, the system was removed and the wound was closed with 3 ProGlide sutures. Pre and post operative echocardiography shows the reduction of gradient. Mitral valve interestingly shows reduction of the mitral regurgitation. As you can see, there is MR on the left image and the right image shows reduction of MR. Again, pre-operative and post-operative echocardiography in the Doppler exam are shown here. Without Doppler, again pre-operative and post-operative valve movements. TAVI, a kidney's perspective. Based on the data from Edward Sapien Aortic Bioprosthetic European Outcome Registry, CKD is one of the strongest independent predictors of 1-year mortality following TAVI. It is well established that patients with CKD carry a higher risk of acute kidney injury. Almidi and others have studied 234 patients with severe aortic stenosis who underwent TAVI between 2007 and 2010 at a single center and found that pre-operative serum creatinine level was the only independent predictor of post-op AKI. Khwaja and others subsequently demonstrated that higher CKD stage is the strongest independent associated with acute kidney injury after TAVR, but number of studies did not detect an association between CKD and AKI following TAVI. The take-home message can be defined from Voilenders et al.'s recently studied the influence of kidney function before TAVI on the AKI incidence in 540 patients. There is a modest increase in GFR in the moderately impaired renal function group and a significant increase in GFR in those with severe decreased renal function. There were no change in GFR after TAVI patients with normal renal function. Improvement of GFR was also demonstrated at 1 month following TAVI in patients with pre-existing CKD, possibly due to improvement of cardiac performance following correction of valvular disease. In our patient, we noticed that after the aortic stenosis was taken care with the TAVI and a new Evolute 29 valve was placed, in fact his renal function improved from a baseline of 1.7 creatinine to 1.5. Final take-home message: pre-procedural CTA replaced the non-contrast CTA or ultra-low contrast CTA or MRI. TAVI should be preferably performed by transfemoral approach. During the procedure of peripheral aortoiliac angiography, avoid by using manual puncture using crossover wire technique and use of CTA MRF frames inside the cath lab in a view box, or you can use ultrasonographic guidance. Do not do any procedural angiography. Use 18 French sheath, preferably in the groin. Aortic root angiography again should be avoided and use of TE is encouraged. Positioning of valve check chutes, avoid and use of TE and proper pigtail position in the non-coronary cusp as landmark should be encouraged. Again, avoid post-placement aortic root angiography and use TE. And post-procedural peripheral aortoiliac angiography should be avoided with the use of manual palpation and use of USG Doppler if required. Proper hydration before, during and after the procedure is very important if tolerated. I thank all of you that you have enjoyed this case. I am Dr. Keyur Parekh from SIMS Hospital, Cardiovascular Department. Thank you again.